Welcome to Airway Breathing Conversation, a podcast presented by the anesthesiology residents at the University of Saskatchewan, created to provide individuals of all levels of medical knowledge with anesthesiology-related healthcare information. This episode is part of our abridged Ground Round series, in which highly knowledgeable and sought-after guest speakers present on a multitude of fascinating topics relevant to anesthesia. Join us for Grand Rounds this week, where Dr. Lilian Thorpe, a geriatric psychiatrist with the University of Saskatchewan, presents an overview of post-operative delirium. Now, whether you are an anesthesiologist, resident, medical student, or member of the general public, come listen in as we demystify the incredible specialty that is anesthesiology, one episode at a time.
Good morning, everybody. I'm a morning person. I love to be here shortly before 7, so this fits in very well. I'm less good late in the evening, and so this is great. Anyway, thank you very much. This is a great topic, and those of you know I work mostly at City Hospital, where many of the acute aspects of delirium may have already been settled a bit post-surgically in the recovery room and so on. I occasionally see them, but more often the sort of subacute outcome of delirium, which are very stressful for patients and families and can have a number of consequences. So this, I think, is a really great topic. And thanks for inviting me. And I'll just make sure I can go here. So our learning objectives are that we are going to talk a little bit very briefly about the type of cognitive impairment seen after surgery. Not everything is delirium. And then talk a bit about prevalence, etiology, what contributes to this, and the diagnosis, and what some of these adverse impacts are on families and patients. And that fits well with Peter's research. Peter has an ongoing research project exploring some of those patient and family impacts of delirium. It's a great study, hard to do, but it'll be great in the end. So, and then a little bit of what we do for the acute symptoms of delirium, which after there already is delirium. So that's what we're going to talk about. And then why bother? So I added this slide because, you know, for every presentation, I want to know why this is even important. And I think we want to talk a bit about the risk factors. And I put right up front here, premorbid cognitive impairment. And a lot of patients I see who come to me with post-operative, supposedly cognitive impairment or delirium, they didn't have an identified cognitive impairment beforehand. But when I talk to their family members, they've been subtle changes over quite some time. And other family members have gradually adapted and taken over tasks. So without clearly identifying that this person has a cognitive impairment. So when they end up in an unfamiliar environment, such as a hospital, whether or not they had surgery, they're often obviously disoriented and impaired, which was not really identified or accepted by family members before. So some of this is perceived as new, but may not actually be new. It may just be more evident. So I don't know what's done in all the pre-op assessments, but I wonder if not, should we have a cognitive screen, something very brief that we could do to get a bit of a sense before the surgery happens. And the reason I think that's important is that otherwise families and patients blame the actual surgery or anesthesia or medications, and that leaves a lot of discomfort, anger, and so on. Whereas if we had some idea that there is a little bit higher risk even beforehand, I think this makes us all feel a little bit better. And so, and patients who think that this was all to do with the anesthetic or the treatment may not be willing to do another important surgical intervention, such as the second hip surgery, which is so important for our patients to be mobile. Anyway, so this is an important thing that we talk a bit about these risk factors so we can minimize them. What are these physical risk factors as well? Which disorders are associated with this? What medications put us at risk? And there are a number of others. And then why bother? Can we modify those risk factors before? So these are the pre-op risk factors and then intraoperative and post-operative. And I think some of the subsequent presentations will focus more on that from an anesthesia and surgical side. And then why bother? Well, we have more information about delirium. We can, in that pre-op assessment or when we first talk to our patients, talk a little bit about this. This is very common that there's a little bit of confusion afterwards. Much of this settles, occasionally doesn't completely. This kind of information is useful for people to have. And I think in the end, learning more about delirium helps decrease distress to our patients, our families, and staff, because it can be really scary having those florid symptoms of delirium with the hallucinations, disorientation, really frightening. So as an example, I see people who see snakes coming out of the walls, absolutely petrified. They see these snakes crawling towards them. They see awful things like faces, demons, things on the ceiling, and it is absolutely distressing. And then they end up getting injections and so on to deal with this, but it's very, very distressing. So, okay, and of course that itself, that distress can put patients at risk because they can act in response to those hallucinations, and these could be things that harm them and others. When they get so distressed, they do very impulsive things. So that's the why bother bit. And long list of references, if anybody's interested, I did send this to Henry, and I as usual, did my obsessional look at the literature, and I listed some of them there. So post-operative neurocognitive disorders, not all delirium. So not everyone that's confused after surgery has a typical delirium fitting with our DSM-5, so Diagnostic and Statistical Manual in Psychiatry, that's the Bible. Not everybody has delirium typically. A lot of patients that I see have post-operative cognitive changes of some kind or another, but not ever fitting this full criteria of delirium. So both of these are really important. And some of these patients do not ever recover fully from their neurocognitive changes that were identified after surgery. So that may be because we were not aware of what was happening with them before surgery, and it may be because something new happened during surgery. So these three are all important. We're talking mostly about delirium today, but we have to remember that these others are important as well. And these are related, but not exactly the same. So I've just put a few articles looking at differences between post-op delirium, post-op cognitive dysfunction. Some things are similar and some things are different about this. So I won't go into a lot of this detail, but it does suggest that there's overlap between these two disorders. And many other risk factors, such as stuff like reduction of thalamic hippocampal volumes and cerebral blood flow and so on, may be associated with postoperative cognitive disorder, whereas some of the other white matter pathology more with other factors, delirium, for example. So there's some information that differentiates some parts of this, but they're obviously somewhat related. So that being said, it is important to keep that in mind when we talk to our patients, because a lot of my students, when they work with me, all they see is delirium and they don't see the typical symptoms of delirium. Then there's they don't see a cognitive change, but there often is. So we are talking about delirium by DSM-5, which basically really is exemplified by disturbance in attention, so that people have trouble focusing on you. They're all over the place. It's a lot like people that we know who have ADHD, the kids who can't focus on anything, or some adults who can't focus on anything. They're all over the place. But for these people, it's a change. So they have trouble focusing and awareness of what's happening around them. And it typically happens within a relatively short period of time, although not always in delirium for etiologies such as medication use. So we're not talking about that today, but there are medications that cause symptoms of delirium that then come on over a longer period of time as the blood levels increase. So basically, though, we assume that this is a change from previous functioning. And here's why it's so important to know how people functioned before, because we actually don't know if it's change unless we've assessed them before. So it has to be a change. And then the kinds of things we'll see memory deficits, which can fluctuate, disorientation, language, visual spatial abilities or perception. So we can see these really frightening usually visual hallucinations, sometimes auditory. I mentioned the person I had who had snakes coming out of the wall and so on. The memory deficits are very fluctuating. So when I see people in the morning, they may be not too bad, but by late afternoon, they're terrible. And in the course of the day, there may be other times that they're very fluctuant. So fluctuancy is really typical of delirium. So we want to note that these disturbances not due to another disorder. However, they are much more common if you have an underlying neurocognitive disorder. And so ideally, we find some sort of underlying etiology for this. And in our surgery and anesthesia, this is our presumptive etiology, although many other things kind of happen that we're not aware of that may add to this. So delirium, of course, so Sharon Inouye, who is a geriatric psychiatrist who's talked the most and written the most about delirium in elderly people, she talked already back in 2014, we all in psychiatry heard her a lot at conferences, that it is very common, it is very serious, it's costly, we often miss it, and it can be a fatal outcome for older people. So typically it has a multifactorial etiology, and then outcomes and interventions also multifactorial are most effective. Unfortunately, there's no evidence that prevention by drugs, so using, say, preoperative haloperidol or risperidone, or even worse, olanzapine, which is very anticholinergic, none of that is not good evidence that prevention by drugs is particularly effective. So, however, she recommended back then already drug reduction for sedation analgesia with non-pharmacological approaches if possible. And then she noted that delirium helps us learn more about brain pathophysiology, which tells us a lot already about the brain vulnerability, because we know that people with delirium have decreased reserve and to start with, and that helps us, knowing that they've had delirium makes us more careful in exploring how they actually were functioning even beforehand. And we can learn a bit from delirium about how the brain may get damaged by those mechanisms related to maybe others. So this is what delirium looks like. We have here impairment of consciousness and attention, so we can't focus. Overall perception, global disturbance, perceptual, abstract thinking, and disorientation. We have psychomotor disturbance. People can get very angry, very unhappy. I see people sometimes fluctuating depressive symptoms with suicidality. People talk about wanting to jump out the window. You heard I'm involved in MAID assessments. I've seen a number of people who, when they first come to hospital with delirium, they ask for MAID now because people know about MAID. And when I go there, two of the cases, the first assessor approved the person, but this was delirium. And after that person settled, no longer wanted to die. So we can have very profound psychomotor disturbances, could also be anger, and aggression against others can be quite challenging. And so it covers a little bit of the next one. And then we often have this disturbance of the sleep-wake cycle. So a lot of those symptoms are not all there at the same time. They can fluctuate. Some are there more than others, and some are more problematic than others at any particular time. So I have all the references in there if somebody's interested, and that's a really nice article on pathophysiology of delirium there. And if Henry is interested in passing on my talk, I'm always happy to share anything I work on so that other people can use it, adapt it, and improve it in their own teaching. So Sharon Inouye talked a lot about prevalence, and I don't think it's much different. So we know that the prevalences are quite different depending on what sort of situations we're in. So the type of surgery somewhat may affect the prevalence of delirium. So actually these numbers are not terribly different, but you can see within each of them, there's actually a really big range. So it probably depends on what kind of cardiac surgery it was, how it was done, how long it took, and so on. So huge ranges in all of these, or in even intraoperative techniques or anesthesia techniques. And then within populations, general medical populations have high prevalences as well in delirium. So geriatric units very high, intensive care units high, post-stroke high, and in dementia it's much more common, right? So in the nursing homes we see this fairly commonly as well. And you see on the right hand column here that mortality in each of these is also increased. So if a person has delirium, this is a marker of potentially poor outcome. They have higher mortality rates than people who do not have delirium. And that may not be because of the delirium, but because of confounders associated with that delirium that may have been etiological in the development of it. So the underlying factors themselves might have been the real reason for the mortality increase. The delirium is what shows us that they're at risk, but it may not be the delirium itself that causes the mortality. But it makes us look at underlying factors. So the pathophysiology, lots of work on what that is, that we have disturbance in neurotransmitters and cytokines at various levels, cortical, subcortical. We have involvement of the reticular activating system, which is why we have such changes in our concentration and focus. And then other things such as hypoxia, thiamine deficiency, you'll see in alcoholism, will have decreased acetylcholine synthesis. And acetylcholine is highly involved with cognition. And we know a lot about it in dementia, but probably also in delirium, significant. So serum anticholinergic activity, important. So here's why I don't like using something antipsychotics like olanzapine, which is very anticholinergic, and in anyone close to, well, actually anyone elderly shouldn't really be taking olanzapine unless there's no other option. Other drugs would be antidepressants, such as the old tricyclics. They're fairly anticholinergic, but as is mirtazapine or Remeron, which is one of the newer ones, also anticholinergic. So some of these great antidepressants, but put us at risk for cognitive impairment. And then we have pro-inflammatory cytokines, interleukin-1, 6, and tumor necrosis factor. And a number of, so you can see a number of things affect this. The biggest one, of course, is aging. So the older you get, the more likely you are to have an episode of delirium. Now, aging, chronological aging, of course, isn't all there is to aging. We are all very different between ourselves, so inter-individual differences. So some people have very intact brains and neurons intact into very old age, but others decline quite young. So I'm seeing people in our geriatric unit that are declining brain health in their 50s already, and I see occasionally patients over 100 who are still functioning completely intact. So even though this is an average, on average, aging is associated with this, but much intra-individual variation in this. So this is a slide you probably can't see. I have it on my big screen beside me here, but this is this is still the same article by Maldonado, which was in an International Journal of Geriatric Psychiatry article. So he summarized some of these etiologic risk factors, such as neuronal aging, neuroinflammation, which is probably more related to actually surgical involvement during these episodes rather than anesthesia, oxidative stress, and then neuroendocrine regulations affecting your hypothalamic axis dysregulation, and then a melatonin, tryptophan, so sleep circadian rhythm. So and then in the end, these things come together to result in a system integration failure. So the brain fails. And so acute brain failure, and you can get a number of these subsyndromal delirium patterns, which can be a full pattern of full pattern or various subtypes, which might be hypoactive. So a patient with delirium might be doing very little, not speaking much, not moving much. And we often miss those because they don't cause trouble. And then we have the hyperactive ones that are all over the place and requiring restraints in bed. Everybody finds these. And then there are mixed ones. And there's some fluctuation even in individual patients. At times they're more hypoactive, sometimes more hyperactive. So there's a blend. And the outcome of this is mixed. So some people have full functional recovery from this, but there are also variable degrees of deficits after delirium of a variety of kinds, and then in some of them, very chronic symptoms of delirium, which can go on for quite some time, and we have increased morbidity and mortality from this. So this is sort of the overview slide, but these are just some of the more detailed discussion from this. I won't go into all of this, but you can see that some of the pathophysiology is quite complex. So we have acute insults, which probably result in some sort of inflammatory event. We have macrophages. We have all kinds of stuff happening here that then end up affecting our brain, and we have a more vulnerable brain when we're aging, especially if we have reduced neurons from dementia. So we have lower numbers of neurons with dementia and with aging in general and within us. And so then there are many kind of neuronal things that can happen to end up causing neuronal damage and death and dysfunction before that, which may be reversible or not entirely reversible. So here is some of this here on systemic inflammatory events. We all know now that cognition has a lot of involvement with system inflammation. So unrelated to this, delirium, for example, is one of our projects I'm somewhat involved in, is looking at dental caries and cognitive decline. And dental caries cause inflammation, and there's some degree of that impact on the brain, and that looks like that's related to increased cognitive impairment. So we know that inflammation is a big pattern, big involvement. We know on brain studies that markers on inflammation are common around in the brains of people who have Alzheimer's disease, and they are themselves involved in further brain death. So inflammation, super important part of the etiological process of dementia. So this is a little bit more on oxidative stress, glucocorticoids. Won't go into a lot of this, but I think the functional connectivity discussion is important, because what we see is really in delirium a failure of integration and appropriate processing of this information, which allows us to have appropriate informed motor responses to what's happening with us. And we have really an acute breakdown in the network connectivity within the brain. And as opposed to seeing the brain as static, most of us now involved in brain-related disorders see this as very much a connectivity problem that is affecting our brain. So it's not just that we have individual neuronal biological change that we can see on a CT scan, but we're seeing things on PET scans that really relate to connectivity and function. And delirium is a great example of that. So here are some of our risk factors. So advanced age, number one. So the older we get, number one. Then baseline cognitive impairment, as I said, often unrecognized by family members, especially in highly functioning people before, because they have compensatory strategies to cover the fact that they're declining. And so it's not aware to family members. Sometimes they know. And physician, very well known to all of us, not using his name, he said, Lilian, I know I'm scoring well on testing. I know I'm not right, because I can feel everything's harder for me. You guys don't notice it because I'm working so hard at it, but I know I'm not the same. And he ended up to have very rapid decline. He was right. So baseline cognitive impairment, often unrecognized in bright people, and then is a risk factor for post-operative delirium. So comorbid diseases, multiple together, Parkinson's, other diseases, risk factors increase these. Increased frailty, which I think Megan Serpan, might be talking a bit more about frailty later. And then drug abuse, alcohol abuse, things that we don't always know that they're taking, and they don't tell us these things and how ill they are to start with. So very sick people are more likely to have delirium. So these are some of the predisposing factors. And then the precipitating factors, what's happened, the hypotension, the sepsis, poor pain control associated with symptoms of delirium. So I'm not sure it actually causes delirium, but the symptoms. And then the ventilation, and then sleep disturbances themselves may not just be an outcome of delirium, but may also be etiologic, in that many of the restorative processes in the brain have to do with deep stages of sleep, normal sleep. So stage 4, we have a lot of restorative processes. So if we impair sleep, that itself might be etiologically significant to cognitive outcome. And so here's some of the medications: benzodiazepines, muddle people, opioids, the sedation level, which I think you'll be hearing more about what you do in anesthesia, what that might affect outcome of delirium. Anticholinergic drugs, I mentioned olanzapine, the tricyclics, ditropan, drugs like that, use of steroids, and then the type of surgery that we have, obviously, as a function, is related to how likely you are to get delirium. And then some of these other more specific factors, for some reason, males seem to score a bit higher, and in individual factors, not sure if that's true information. So really thin people, lower weight people, smokers, lots of these individual factors that put you at risk. COPD, And then some of these operative factors, which of course I know zip all about, you guys will talk more about, but the types of anesthesia you have, whether you've had transfusions, whether it's elective, if they've had to wait for a long time for surgery. So during COVID, the worst of COVID, our patients waited for absolutely ever for the surgery, and they're in a lot of pain. They're doing a lot of self-medication for pain. They're not moving much. They're sitting a lot. They're losing mobility. They're losing lean body mass. So they're generally getting sicker while they're waiting these incredibly long wait times for surgery. This is a problem. And they get much sicker by the time they go into surgery. We're all seeing that now, where we're catching up with surgeries and our patients are much sicker now. Okay, so commonly used medication, just a list of them here, that antidepressants, of course, but antihistamines as well, antimuscarinics, oxybutynin and tolterodine, those used for bladder. Many of these drugs are anticholinergic, which affect our cognition. So olanzapine here, paroxetine, even of the SSRIs, some of them more anticholinergic than others, such as paroxetine. And then corticosteroids, meperidine, and some of these more sedative hypnotics. And then, of course, the more drugs you're on, the worse it is. And some of you know that much of what we do in our geriatric program is deprescribe, or some people have called this decrapification, and our elderly patients who come to us on over 20 drugs, sometimes way more than that. And so the more drugs you're on, the more risk of delirium you have. So what does this look like? We are seeing people who are not sleeping properly. They're up and down all night. The staff are putting restraints on them at night. They are having these vivid dreams, and they often have trouble distinguishing these from real things. So they think people are coming into their room. These kind of hallucinations and then delusions secondary to that, often based on previous experiences. So you'll see people who've had trauma in their lives have much more frightening response to these hallucinations than others. So having had absolutely traumatizing childhoods, particular early life experiences, they can really trigger panic in people and terrible responses. So somnolent daytime experience, you're really not functioning very well. And so this we often see people are not really fully intact. And so these emotions, fear, anxiety, depressive symptoms I talked about. And this is from our Canadian mental health guidelines on delirium, which are all available online. This is from our Geriatric Psychiatry Canadian group. So thought disorders, impaired organization, utilization of information, bizarre thinking patterns, especially in delusions, especially persecution and poor judgment, insight. We do things that are impulsive and not in our best interest, those kind of things. Often speech finding, and sometimes we have trouble differentiating that from a stroke. My fourth year medical student who's on the call today, yesterday, was interviewing someone for me, and actually picked up when she was listening to the patient that had speech abnormalities and eventually had trouble speaking, that the patient was having a stroke, and she called a stroke alert. And so sometimes we're not entirely sure what this means. We have to work hard on figuring this out, but by itself, we may see this just in delirium. And this other stuff, memory orientation, poor registration, so they're not remembering what we're telling them. That confabulation is when we mix up the past knowledge from whatever sources that comes and the time we got this information. And so sometimes we say things that sound like delusions, but they're really that we've got our brains jumbled up, and we heard something on a television and we think it was today and it actually happened. So we've mixed up what we've heard, what we've seen, what we've read, and when it happens. This is confabulation. It's a little bit different than delusions. And then the disorientation, of course. All right. So then these perceptual disturbance, I'll just list some of them. Macropsia, seeing everything larger than it is, micropsia. I have a number of times seen people talk about tiny little people walking across the room, or tiny little animals. And so you see that sometimes. You'll see derealization, where people think everything is unreal around them, or they don't feel real, or they misinterpret what's around them. Illusions are misinterpretations that are based on a real stimulus, but they are misinterpretation of that. And then the full hallucinations, which is nothing's really there, but you see something or hear something. And they can be in a variety of ways, but mostly visual, and they'll happen often more towards evening at nighttime. So, and then COVID particularly had, people who had COVID had possibly higher rates of delirium, and of those, they had lots of agitation and maybe more myoclonus and abulia, which is like apathy, not doing much of anything, and alogia, not speaking. So there's some things that were a bit different about the COVID-related deliriums we were seeing. And there was some suggestion that low-potency neuroleptics and alpha-2 adrenergic agents might be useful in this setting, but there's not great data on this. Okay, so types of delirium we see are, they start with a prodromal phase where we see some restlessness, anxiety, irritability, sleep disturbances. And then that sort of fluctuates a little bit, sometimes stays and gradually gets worse. You'll see it happening over the course of a few hours or days. And then you get into a more full delirium where you see a lack of activity. So lack of initiative, lack of involvement, a person becomes very flat, doesn't do anything. And these ones here cause no trouble, and often we miss them, as I said before. And these hyperactive ones, which we don't miss because they drive all the nurses crazy and they're into everything. And this could be highly risky to others and patients because we see people going around undoing people's IV poles and picking up things and swallowing them and stuff. So all kinds of stuff can happen. But the hypoactive ones themselves have worse outcomes. And then we can have some chronic or persistent delirium. Again, I summarized that before. And so here are some of our subtypes and outcomes, which again, I think I've just mentioned already. So multiple outcomes that can happen. And there are people who have this almost now this discussion about catatonic delirium where people do nothing whatsoever. They're just completely frozen. You don't see this very often, but you'll sometimes see this catatonic delirium as opposed to the more typical ones we see with hyperactive or mixed. So then so this was the hyperactive, decreased attention, focusing, restless, and then the hypoactive, drowsy, and somnolent, and then mixed, a lot of them. And the ones with hypoactive delirium more likely to be older folks, some more risk factors of anemia with them, and they have a much higher mortality than the hyperactive delirium. So for whatever reason, this is a bad outcome. Now, it's possible some of this is because we miss it, but it may also be that what leads to this hypoactive profile may be also what leads to poor mortality. So adverse effects, so you see some of the stuff, bad stuff I mentioned, pulling lines out, tubes out, not in yourself, but others. So I've had patients go around the ward and pull out tubes of other people. And so obviously this could be a problem. And then, so these active ones, whereas the ulcers are more common in hypoactive because not moving, right? So survival rates, just to show you, so this shows the hypoactive ones, the full syndromal deliriums have decreased survival. So this is a Kaplan-Meier survival estimate following people after acute medical admission. So you can see that these are decreasing as time goes on, their survival. And this is compared to delirium, no delirium. Okay, so we do know that mortality is considerably greater in older people who have had delirium, and in ICU, particular odds of mortality compared to the average. So even although there's been a lot of delirium research, we still have really high rates of mortality after ICU delirium. So yeah, so what do we know? And it's kind of hard to know sometimes. You know, some studies have looked at, if you look at all the confounders that are associated with delirium, if you control them very well, some of these studies have not found that this itself, delirium, increases mortality. It is a marker of underlying comorbidities that are the real cause of this. So etiologically, it may not be delirium itself, but it may be, if you fully control in your models, that there are the other factors, confounders, actually responsible for this, but it's maybe a marker. So, but many studies show that if you have this clinical presentation, you have increased mortality. So this is a lot of meta-analyses, and there's an interesting more pathologic study that looked at the correlation between genetic risk factors for Alzheimer's and delirium. And this is obviously a big risk factor for delirium, even if you don't have obvious diagnosis yet, if you have the strong genetic subtypes that are associated with Alzheimer's disease. So I thought it was an interesting study, and it makes sense. So then, why is this important to family members? And this is, patients can sometimes recall this. This is really frightening to them. They can have PTSD after this, post-traumatic stress disorder, and it can be also traumatizing to family members because people can say terrible things. And they can physically, as I talked about before, actually have physical damage to them. People can talk about jumping out the window and doing things that are really highly impulsive. But their post-experience can also be difficult. And family members, it's distressing. Professional staff dealing with delirium, the nurses, can be tough. And patients and families can have sequelae that are psychological, so the PTSD. So this is why bother, as I put right at the beginning, because we can give a bit of information about this. Yeah, so after your surgery, these are the things that might happen. These do not usually last. This will go away in almost all cases. Just letting people know what might happen is super, super helpful. And just knowledge is helpful to prepare yourself and cope with something that's happening. Okay, so caregivers, lots of stuff on caregivers of patients with delirium, and it is quite distressing sometimes. In palliative care settings, we have really high rates of delirium when people are dying. People can have really difficult deaths in the palliative process. As they're dying, they go into gradually progressive brain failure. So this could be gradually over weeks when somebody's in palliative care or receiving it at home. This can be really difficult when a person is then hallucinating and agitated and not who they usually were. And the memory of that person then is always affected and colored by this awful experience with them at the end of the dying process, which is why some of us ended up doing medical assistance in dying, because it is a more peaceful process at the end of life for some people. So families, about 27% of ICU survivors suffer from PTSD. Many of our post-op patients end up in ICU for a while. And then some of these things are risk factors: use of benzos, duration of sedation, and how fearful they are, then are risk factors for PTSD afterwards. And PTSD afterwards is not only distressing, but could hold people away from having appropriate surgical interventions later. They're too afraid of having any treatments because of how awful this was. And that's damaging. So what do we do? Okay, so this is our guideline to what we should do. And when we think there might be delirium, we want to have a baseline cognitive function. So it'd be nice in pre-op clinics, and I don't know, maybe this is done, to do a brief cognitive screen. Maybe that's just done. But then that way we know of what's changed afterwards, get a bit of a history from family members. Was there some decline overall? Did the family member have to start doing things for them? What drugs are they using? And then vital signs, looking at delirium with treatable interventions. Do they have infection, dehydration? And then some laboratory investigations. This kind of stuff we teach with our students. What might we order for these with laboratory investigations? And then focal neurological changes. And so as my student Morgan just picked up, that this was actually a stroke she was seeing, and this person did have massive stroke there. So anyway, so being alert to neurological changes, since stroke can also present as delirium. And we tend to see what we do all the time. We trained, and so psychiatrists see psychiatric things, surgeons see surgical things, but I think we have to remember that we all first physicians, and we have to remember that we assess people in a holistic way, not looking at just our particular area of expertise, but in a holistic way, what is actually happening with our patients. So EEGs in some situations, because you can get seizures, so limbic seizures look very much like a delirium. So this is a guideline for our assessment. Some of the challenges that our family members have not recognized the underlying dementia because it's been very gradual. Families have taken over. In a home, they know where everything is. They don't need a lot of new learning, and you see this in hospital where they don't learn from minute to minute what it is that they've just seen. So in a home, you don't notice it. Everything's in the same place. And then a really bright person, we all have the world view of that person is very bright, as does that person, and they have a great difficulty accepting that they're impaired. And so they may be quite impaired. Guy I saw yesterday in our geriatric program, very high functioning guy before. He is absolutely fixated. There's nothing wrong with him. And he's really demented now. So his view of himself is very high. The family too took years to come around to the fact that this guy was really impairing. So then here's the problem, that when we get a second party information about how they were doing, often the next of kin is as impaired or more so. So Morgan, who just picked up our stroke, she was interviewing the wife of a patient who had even worse dementia. So we've seen both of them now. And so the information we get from the next of kin might even be worse than the information from that person themselves. So then, or we could have next of kin like the daughter from California syndrome or from Calgary syndrome, where they hardly ever see the patient and they really don't get it. And so they think that person, their parent, was doing just fine, and they actually weren't. So then other challenges with diagnosis are that it fluctuates and that there are windows of normality. So you will see a person function quite normally for a bit. So a student will come and say, oh, Dr. Thorpe, this person's completely fine. I'll go back. And I go back and this person's right out to lunch. And so it's so fluctuating. So we want to really see a person at a number of different time periods or get information from the staff. And now the subtle symptoms of hypoactive, so when people are not doing anything, often missed by busy staff. Now, we have a tendency to think everybody's depressed these days. We put everybody on antidepressants for life circumstances or apathy, for which it does not work. And we mistake this. People are quiet and withdrawn. We think they've got to be depressed. Well, that's not necessarily the case. And antidepressants have drug side effects like anything else. And we have an epidemic of excessive antidepressant use right now. So if we sedate people enough, we actually don't know that they have a delirium, and their delirium might be a lot worse if they're already anxious people who worry about everything anyway, so their symptoms can be difficult and hard to differentiate. And then I mentioned before the trauma, so people who've had pre-existing trauma can be highly emotional with some of these frightening hallucinations and so on. And especially restraints, they can be absolutely panicked with anyone restraining them. I am almost done here, so you guys are all probably burnt out. So the number of tests you can do for a delirium, there's the confusion assessment method. That's the most common one that one might use. There are a few other screening scales and that you could do. The confusion assessment scale is the one that you might see the most often in research related to delirium, which looks at the acute changes in mental status and fluctuation, the inattention, the disorganization of thinking, and the altered level of consciousness. And so this one is the most common one you will see. And so I know most of you will not use this, but if you are studying this, one sees this. So what do we do, practically speaking, to try to prevent delirium? Well, I think, and this is from a research article back 2019, I personally think before that is getting good history from family members. But on the day when we get patients, make sure they have their glasses, hearing aids, to make sure they're oriented, that they sleep well as much as possible, they get out of bed as quick as possible, they have good pain control, that we early pick up the post-operative complications, we keep them hydrated. And hospitals are really busy, so sometimes I'll come to see a patient who's too muddled to actually eat their breakfast. The breakfast tray is sitting there, it's been there for an hour, and this patient is too muddled to even eat, and they're dry as heck, so they can hardly talk because their mouth is so dry. So nurses are busy, and if that person is quiet, not making a fuss, oftentimes they're not getting enough oral intake. And then bladder bowel function, and then oxygenation. So I've seen a number of deliriums where a person has a trouble breathing when they're flat. So they obviously have, especially very obese patients, you put them flat in their back, they can't ventilate properly. They get hypoxic and then very confused and symptoms of delirium. You sit them up and deal with their oxygenation, they're less so. So what do we do with treatment? We treat the underlying causes as much as we possibly can, which is all of these things we know about, their hypoxia, their low blood pressure, glucose levels, the various drug withdrawal. I haven't talked about alcohol withdrawal, their challenge. And then we might have multiple causes. So the older a person is, the more likely they have stuff wrong with them. So underlying anticholinergic issues, we might be able to use a cholinergic. So multiple causes. We want to be careful about our fluids because it's hard to balance this sometimes. Don't fluid overload them. And then these folks who don't tell us they've been drinking like a fish before they came in. Oh my goodness, people have incredible alcohol intakes. Again, yesterday, a fellow, I think it was yesterday now, took like a Mickey every 3 days that he admitted to. And I'm sure he took other things as well. So they don't always tell us what they're taking. And then what we do is reorientation, memory cues, calendars, clocks in the room. We do a lot of this now. Family photos to make them feel familiar. And ideally, a family member can even sit with them to make them comfortable. So we keep the environment as stable as we can, quiet, well lit, so they can see what's around them. And then reduce noise. Earplugs if we need it. Somebody doesn't sleep well. They are more muddled the next day, and sensory deficits, as much as possible, get those glasses on, hearing aids on again. And then family members and staff, be there to reorient that person, reassure them, and sit with them is often much more effective than heavy medication use. So familiar nurse, family support, bringing in sometimes private nursing occasionally helps if that nurse is known to them. If we can avoid restraints as possible, sitters are probably better. Restraints are really terrifying for people sometimes. So, and then pharmacotherapy, we want to treat the symptoms that might be driving this, but the pharmacotherapy for delirium probably doesn't lower the risk of dying, actually. So giving our antipsychotics, our haloperidols, probably doesn't lower the risk, but or even shorten the hospital stay, but it can improve the health-related quality of life. So we always wish that what we do would actually make people live longer, but it doesn't look like the data suggests that. And so this is just showing what I'm saying. The antipsychotics don't actually low. So this is just backing up what I'm saying, so you don't have to go into all this. So there's really not a lot of evidence that there's any long-term benefit, but there's short-term symptomatic benefit from some of these. So we're looking at, so the alpha-2 agonist. I've never actually used this, but there's a lot of data on this now with medetomidine, I can never say this right, and I know some of the folks in ICU have had experience with this, may shorten the duration, and then some of these are helpful, but in terms of changing the length of stay, probably not so much, or even mortality, so more symptomatic. And so cholinesterase inhibitors, definitely not, nope. And these are not useful in the best of times. Even with people with dementia, they have way more side effects than any benefits, but especially in treatments for delirium, no benefit. So ideally we use, if we do have a lot of florid symptoms that need treatment, we use antipsychotics at the lowest effective dose, the shortest possible time, and ideally those that are not anticholinergic, such as olanzapine. And we stick with haloperidol, or once they're taking oral medications, risperidone, so you can give that liquid or oral, and sometimes those deliriums last for a while, so we end up giving risperidone rather than haloperidol because risperidone has less EPS likelihood of causing that, so let's stay from it, and it's generally well tolerated and not anticholinergic. So both Haldol and risperidone reasonable choices, and then, but really only if we need to use it, and then we don't need to ideally not use it if they're not agitated or really, really distressed. So less is better. And then benzo shouldn't be the first line. except for withdrawal syndrome sometimes. So if you are going to use them, shortest possible dose, only if absolutely necessary. So then I won't go into all these different syndromes, but psychotic symptoms obviously are going to benefit most from a neuroleptic. Agitation is also used similar kinds of treatments, but occasionally anticonvulsants like sodium valproate, and then some of these other alpha-2 adrenal receptor agonists and so on. So this sometimes for the agitation. And then the insomnia is quite difficult to treat because using benzodiazepines might make things worse. And the opioids for pain have their pros and cons as well. So sometimes melatonin, but it's really mixed data on melatonin, not great studies. So these are just listing these antipsychotics. So haloperidol, obviously the acute use can be used IV, intramuscularly, or orally, but a Haldol has a high risk of causing extrapyramidal symptoms, Parkinsonism, and in high levels can cause you to have actually choke. So not very tolerable in high doses. So we have to watch it in these. So acute situations, yes. Quetiapine is more sedating. It's got a little bit of anticholinergic, but you can only give it orally. So it is nice at bedtime. So bedtime, not a lot of anticholinergic. It's probably better than the benzos and maybe some of these other sleeping medications. And so it's probably reasonable to use. And then people who have both Parkinson's and Lewy body dementia, you really have to use atypical antipsychotics like quetiapine because they won't tolerate Haldol. And so they get extremely stiff from that. So these are just some of the recommended doses. So ideally lower doses. So this is mostly for elderly, but that is who most of our post-operative delirium patients are. So low doses of Haldol, 0.25 to 0.5 BID. Olanzapine, if you absolutely have to use it, which I strongly recommend you would not use. This is an older study now, guideline. And then risperidone, quetiapine. So I would probably take olanzapine right out of this list. So we do want to monitor QTCs and extrapyramidal side effects as well as sedation with these folks.
You've been listening to Airway Breathing Conversation, a podcast hosted and presented by the anesthesiology residents at the University of Saskatchewan. Please note that while this podcast is run by healthcare professionals, it is intended for educational and entertainment purposes only. We are very thankful to our guests for taking the time to share their wisdom with us this episode, and a very special thanks to you, our listeners, for tuning in. Don't forget to follow us and our associated USask Anesthesia accounts on social media. You can find all our social media links on our Linktree page at linktr.ee/abc_podcast. You can also find the department's social media links on their Linktree page at linktr.ee/usask_anesthesia. We'll see you next episode, but until then, stay calm, take a breath, and always remember your ABCs.